past President Dr. Suresh Kudwa sir, and also welcome our Secretary Dr. Manjunath Nekar, and most important today's speaker Dr. Ravi KR, who is a nephrologist. This is our second IMA AMS meeting, and also I welcome all other members, and Dr. Ashwini Madam is supposed to be like family members of Dr. Ravi. And once again, welcome all the members for this second meeting of IMA AMS. Quickly, I'll request Dr. Manjunath Nekar, Secretary IMA AMS, to introduce today's speaker. Dr. Manjunath.
Good evening to all. It's my pleasure that I am introducing a dedicated nephrologist, Dr. Ravi Kya. He did MBBS in WIMS Ballari in finished in joined in 1998 and finished in 2004, and then MD Medicine in Netaji Subhash Chandra Bose Medical College, Jabalpur, and in 2008, and DNB Nephrology from St. John's Medical College, Bangalore, and he finished in 2012, and he has many research works for his in his honor, and he worked as a chief consultant nephrologist at Sahyadri Narayan Multi-Specialty Hospital since 2017, and also as a chief consultant nephrologist at Vatsalya Hospital, Shivamogga from February 2013 to December 2016, and as a senior resident in nephrology at St. John's Medical College Hospital from 2012 to 2013, and senior resident in nephrology in Premier Institute, like the Institute of Nephrourology, Bangalore, for a year. And he has many awards in many national and international conferences. And he's been involved in public awareness programs. And recently he has given many YouTube awareness videos are also there. And he is very active in these public awareness programs. And his special interests are critical care nephrology, channel catheter insertion for hemodialysis, adult and pediatric renal biopsy, renal transplant follow-up, and plasmapheresis. Over to you, sir.
Nekar sir, just a small interruption, sir. I'll just share the screen. You can go ahead and read the IMA prayer, sir.
Yes.
Thank you, Manjunath.
Yes, sir. It is shared, sir.
Shall I read the IMA prayer?
Yes, sir. Yes, sir.
Yes, sir. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. And flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in Committee of Nations. Jai Hind, long live IMA.
Thank you, Dr. Manjunath. Quickly, just President sir, I request President sir to say 1 minute, few words. Chinwal sir. John, mute moderator. President sir, Chinwala sir.
Logo target, sir, is reconnecting.
Okay.
I'll call him, sir.
Okay. Then I will proceed with the talk.
I just I'll call, sir. 1 minute.
Okay. Okay.
Pulki Patil sir has little network issue. It seems. He said go ahead with the talk.
Yeah, we'll start then.
Yes,
Sir, Ravi sir, yeah, we can
Yes, sir.
start, sir.
Sir, you can share the screen instead.
Yes.
yes, sir. At the outside, sir, good evening, all the members of IMA Karnataka State Branch. For today evening, I would be grateful and thankful for providing me an opportunity to discuss the topic of my interest about the kidney diseases. So for this, I would be thanking the President of IMA Karnataka State Branch, Dr. V.V. Chiniwala, sir, Honorary Secretary of IMA KSB, Dr. Surya V, sir, and also special thanks to arranging the today's academic week with the chairmanship of Dr. S.Y. Multi Patel, sir, and a special thanks to my MBBS classmate and good friend, the Secretary of IMA KSB AMS branch, Dr. Manjunath Mehta. Good evening, one and all.
Yes, sir. It's visible, sir.
Yes, sir. Visible, sir. Thank you, sir. So today I'll be discussing with you all about a very pertinent topic in our day-to-day practice. As a physicians, as surgeons, as a general practitioners, as a doctor in the patient management. In our day-to-day course, we come across many patients who come to us with saying history of some kind of renal dysfunction. So in this present situation, we have to know something about the kidney because it's a very important organ for all of us. We all know that. So when you have a situation of a patient coming to us with kind of renal failure or renal dysfunction, so how pertinent is our we should know to approach a patient with renal failure. In the following discussion, I'll be telling about the approach to a patient with renal failure, and I will also be discussing about the acute kidney injury management prevention, very important aspects in the management. So when we think about the kidneys, and when we are discussing about the renal dysfunction, we have to know about the basic anatomy and the microscopic structure of the kidneys. We all know that the kidneys are supplied by the renal vessels, that is the renal artery which arises from the aorta, which subsequently becomes the minute form of the blood vessels, that is the arterioles, which supplies to the main functioning organ of the kidney, that is the glomerulus. And from here, the blood is taken back to the efferent arteriole. And once the kidneys produce urine, they pass through the collecting system and they pass through the collecting ducts and then the renal pelvis and through the ureter and the bladder, it comes out of the kidneys. This basic structure of the kidney anatomy, both microscopic and the gross anatomy, is very important for us in today's discussion because the points pertinent to renal failure, its etiology, diagnosis, and management depends on which structure of the kidney is primarily affected in our patients of discussion. So, moving on, we also need to know we have to refresh our understanding about the functions of the kidney. We all know that kidney is the main organ which has got a main excretory function. It is the main organ which excretes all the metabolites, urea, creatinine, and the products of metabolism out of the body. It is the function of which is helpful in elimination of the drugs and toxins from the body. This is the main excretory function. Apart from this, the various most important function of the kidney is the homeostatic function. That is the maintenance of the water balance, electrolytes balance. That is electrolytes means sodium, potassium, magnesium. All these things are mainly because of the homeostatic function of the kidneys. And not to mention is the maintenance of the acid base balance of the body, which is kidney is the main organ which functions for the acid base balance in the body. So apart from this, there are endocrine functions of the kidney, mainly in the production of the renin, angiotensin renin by production of the renin from the juxtaglomerate cells. It helps the maintenance of the renal perfusion and the blood pressure. And erythropoietin hormone, which is essential for maturation of the hemoglobin, are produced by the endothelial cells of the peritubular capillaries. Apart from this, kidneys also have production of prostaglandins. And we all know that vitamin D is converted to the active form by the alpha hydroxylase enzyme in the proximal convoluted tubule under the effect of the parathyroid. So these are the main functions of the kidney, and we need to know about this when we deal about acute kidney injury. Whenever you have a patient with acute kidney injury, mainly the excretory functions and the homeostatic functions are primarily affected, whereas a patients with chronic kidney disease, apart from this homeostatic and excretory functions, they also have effects on the hormonal and metabolic functions of the body. So renal failure is not is not a very broad concept. We have to divide it into whether it is an acute kidney injury or a chronic kidney disease, or a pre-existing acute kidney injury superimposed on a chronic kidney disease. So renal failure is divided into these three situations. To understand better about kidney failure, we'll try to discuss about diagnosis and approach to an acute kidney injury by these case scenario. The first case scenario is a 55-year-old gentleman with no history of other comorbidities, presenting with history of febrile illness of 7 days duration. He had headache, vomiting, muscle pain, and he had developed swelling of the lower limbs. He was non-diabetic or hypertensive, and BP was normal, and there was pedal edema. And on further evaluation, it was found that his creatinine is 3.2. This is case scenario number one, where we have a 55-year-old gentleman with no previous comorbidities with an acute insult in the last 3 to 7 days, presenting with a deregional problem. This is scenario number one. So what is this? He has a renal failure. How to deal with this? This is scenario number one. Scenario number two is, again, it is a 55-year-old gentleman with history of diabetes and hypertension in the history, taking medicines for that. He comes to us with worsening edema, easy fatigability, and on clinical examination, he has got pallor, he has got fluid edema, and he has got high blood pressures. Here, on evaluation, it was found that creatinine was 3.4. So these two scenarios, the case scenario 2 is a 55-year-old gentleman with premorbid illness, diabetic hypertension, presenting with features of renal failure. So we have two clinical scenario where we have patient with renal failure, but in a different setting. So, and this scenario will help us to understand more about kidney disease. So this is the slide which help us in differentiating the patient, whether you are dealing with an acute kidney injury or a chronic kidney disease. When you say that the patient having acute kidney injury, you should have a thorough history, examination, laboratory finding, and the imaging modalities which help us to diagnose this patient whether it is acute or a chronic kidney disease. The patients who are having acute kidney injury will present in immediate onset disease. They have a setting of acute kidney injury, probably following a febrile illness or following a dehydration or some taking medicines or infectious illness. And these patients are generally normotensive, or because of hypovolemia, they may be hypotensive. And clinical examination will show edema and have delayed RFT. But these patients have an acute insult, and they usually don't have any other comorbid illness, and they usually present with multi-organ dysfunction. And on further evaluation, ultrasound shows normal kidney. This is how generally a patient presents with acute kidney injury. Whereas the patients with chronic kidney disease, they have many other comorbidities like diabetes, hypertension, and they have renal failure, pedal edema. And generally, patients with chronic kidney disease will have hypertension. 80 to 90% of the patients who have chronic kidney disease will have hypertension. Generally, because the illness is very prolonged, they will be anemic, and they will have features of proteinuria, low hemoglobin, and calcium and phosphorus disturbances. And surprisingly, these patients who come under the category of chronic kidney disease, tolerate the elevation in the creatinine very well. For example, if the patient with acute febrile illness like malaria, acute gastroenteritis, they don't tolerate the elevation in the creatinine as much as the patient with chronic kidney disease. 3.5 creatinine, 4 creatinine in a patient with chronic kidney disease, they'll be walking, talking like a normal person. However, a patient with acute kidney injury with a worsening of kidney function, they don't tolerate it. So tolerance level in the patient of kidney failure will always tell that a patient who is more tolerant favors more in favor of a chronic kidney disease. And imaging also will help us to know a chronic kidney disease patient will have a shrunken kidneys or a smaller kidneys, which are more favor of a chronic kidney disease. So we're moving on to the present day topic, that is an acute kidney injury. So there are more than 30 definitions which are published in the literature which tells about an acute kidney injury. Generally, an acute kidney injury by definition is a sudden, sustained and usually reversible decrease in the glomerular filtration rate occurring over a period of hours to days. So a definition itself says that it is a sudden onset. But there is one point which says that not acute, all acute kidney injuries are reversible. Few of them may have irreversible disease, which we'll discuss in the next few slides. So there are a lot of definitions which says what is acute kidney injury. So the KDIGO, that is kidney disease improving global outcome. This is the definition given by KDIGO, which says that acute kidney injury can be any of the following. That is, increase in the serum creatinine by more than or equal to 0.3 milligram per deciliter within 48 hours, or increase in the serum creatinine by 1.5 times the baseline, which is known or presumed to have occurred within the previous 7 days, or it could be a urinary output criteria, that is, urine volume less than 0.5 ml per kg per hour for the last 6 hours. So the KDIGO definition involves both serum creatinine levels and the urine volume output when defining a patients with acute kidney injury. So, along with that, the KDIGO also classifies acute kidney injury into various stages. That is, stage 1, stage 2, and stage 3. Stage 1 is mild disease, stage 2 and stage 3 are more severe disease. And when patient is anuric or the patient is on dialysis, the KDIGO classification of acute kidney injuries, KDIGO stage 3. And the cardio classification involves not only the serum creatinine levels, it also involves the urine output of the patient. So apart from this, we have one more classification, that is the rifle classification. The rifle classification, apart from looking at the glomerular filtration rate, that is GFR and the urea, it combined both the things and it divided the acute kidney injury into RIFLE, that is risk, injury, failure, and we have loss of kidney function and ESRD. So the risk of kidney failure depends on the serum creatinine levels and also on the urinary output. And it included two more classes, that is loss of kidney function. That is when the patient has got deranged kidney function, deranged creatine, which happens to be occurring for more than 4 weeks. This comes under the classification of the rifle criteria L, that is loss of kidney function. And there are few case scenarios where the patient may have acute kidney injury but ends up being a chronic kidney disease. And the rifle criteria for AK involved this patient also where creatinine is persistently deranged for more than 3 months. So these are the two additional things which are mentioned in the rifle criteria for acute kidney injury. So this is a chart which shows the relationship between the glomerular filtration rate and the serum creatinine level. And the fall in the GFR and serum creatinine is not always linear. It has been found that in early renal disease, there is large change in the GFR, but the creatinine levels changes very little. It happens in early renal failure, where initially you can see that the GFR has fallen very much, but the creatinine rise is not very much. This is seen in early patients of renal disease. However, when we see patients with advanced renal failure, we can see that the rise in the creatinine is large. For example, patient creatinine has gone from 6 to more than 10. However, the GFR fall will be very less. So, increase in the serum creatinine and GFR is not linearly related. And sometimes in early kidney disease, there can be a more fall in the GFR and less change in the serum creatinine levels. That is the reason in patients with acute kidney injury, you have to combine both serum creatinine levels and urinary output criteria to diagnose and treat the patients with kidney disease. And these are the few terminologies which helps us in management of renal failure. And what is azotemia? Azotemia is a situation where there is accumulation of nitrogen waste. That is what is mean by azotemia. It will be a high burn and urea levels, which says that patient is having azotemia. What is uremia? It is the clinical manifestations of azotemia. That is, patient will have edema, patient will have acidotic breathing, patient will have uremic manifestation in the form of vomiting, pericardial rub, or it can be uremic encephalopathy. That is called as uremia. And urinary output, it could be oliguric, that is a measured urine volume of less than 400 ml over 24 hours is what we call as oliguria. And anuria is where urinary output in 24 hours is less than 100 ml is called as anuria. And we'll move on to looking at the epidemiology of acute kidney injury. Acute kidney injury is very commonly seen in our patients and also in hospitalized patients. About 5 to 10% of the hospitalized patients can have acute kidney injury, and the incidence of acute kidney injury AKI is very high in critically ill patients, and 70% of the patients in critical setting is having they have acute kidney injury, and about 5 to 6% of the ICU patients require renal replacement therapy, that is dialysis. So when we look into the further classification of acute kidney injury for the management, etiological perspective and treatment, we divide acute kidney injury into three different types. That is the pre-renal one, the intrinsic renal one, and the post-renal acute kidney injury. So acute kidney injury is basically three types: the pre-renal acute kidney injury, intrinsic acute kidney injury, and the post-renal acute kidney injury. This classification is mainly done to manage the patient in etiological wise, management wise, and the prognosis wise. And pre-renal acute kidney injury, by definition, it is pre-renal. That is, there is renal hypoperfusion. It could be hypovolemia, shock, gastrointestinal fluid loss, or it could be because of vasodilation and other cases of heart failure. That is, acute kidney injury is because of decrease in the perfusion to the kidneys. Whereas the second type is the intrinsic acute kidney injury, where there are situations where the kidneys, the glomeruli, tubules, and the interstitium are affected. And the post-renal acute kidney injury, that is third type, where by the definition, post-renal is after the kidneys. That is, the problem in the obstruction of the ureters or in the bladder or in the outlet. This is what is known as post-renal acute kidney injury. This three classification is very important for us to look into the workup, etiology, and also the management of acute kidney injury. And as I said, acute kidney injury could be pre-renal, intrinsic renal, or the post-renal. And this is how various causes are there, causes of acute kidney injury. So when we look into the pre-renal type of acute kidney injury, a pre-renal acute kidney injury is the most common cause of renal failure. Acute kidney injury. 55% of these patients by etiology is pre-renal. So perirenal acute kidney injury is basically a physiological response to mild to moderate renal hypoperfusion. So prerenal acute kidney injury by definition is rapidly reversible upon restoration of the renal blood flow and the restoration of the glomerular filtration pressure. Whereas if the renal acute kidney injury persists for a very long time, this may move on to become an ischemic injury of the renal parenchyma. Here, the prerenal acute kidney injury, if it doesn't improve with the adequate treatment, can move on to an intrinsic acute kidney injury. And hence, prerenal AKI and intrinsic renal acute kidney injury are part of a spectrum of manifestations of renal hypoperfusion. And the second type of acute kidney injury is the renal or intrinsic AKI. And here we discussed in the first slide that the various microscopic structure of the kidneys are very important in diagnosing and treating intrinsic AKI. In the microscopic structure, we have the glomerulus, we have the tubules, we have the interstitium, we have the vasculature, and also we have the collecting tubules. So the intrinsic AKI can be divided into tubule, interstitium, glomerulus, vasculature, and also the tubular obstruction, looking into the various etiologies of intrinsic AKI. And in these each subtypes of intrinsic AKI is the most important thing is the acute tubular necrosis. Acute tubular necrosis, we have come across many situations where you would have given some toxic drugs or you could have given some other medications which can cause ATN. And when we discuss about acute tubular necrosis, most common cause of acute tubular necrosis is sepsis. Then most common cause is ischemia, that is because they prolonged pre-renal azotemia, hypotension, hypovolemic shock, cardiopulmonary arrest, cardiopulmonary bypass. Apart from this, there are direct toxic injury. It could be endogenous toxins or exogenous toxins. Endogenous toxins are rhabdomyolysis, hemolysis, and exogenous toxins causing acute tubular necrosis are our drugs, basically radio contrast, aminoglycosides, or any other uh, chemotherapeutic medications. What exactly happens in acute tubular necrosis is there will be a ischemia or toxins which are directly affecting the renal tubules, and the epithelial cells are damaged because of this ischemia or toxins, and this causes a destruction in the tubular function of the kidneys. We all know that tubular function of the kidney is very important in maintaining the volume status, electrolyte balance in the kidney, and when these tubules, the epithelium is damaged, the concentrating capacity of the tubules are affected, leading on to renal failure. However, we have what you known as proposed tubular progenitor cells, which are getting activated because of the signaling, and this causes regeneration of the epithelial cells, and this is how epithelial regeneration would have happened, and that means the tubular injury is recoverable with suitable treatment. So, when do you diagnose? How do you diagnose these kind of an acute kidney injury patient is there? How do you diagnose whether it is a pre-renal acute kidney injury or a acute tubular necrosis? So to diagnose, we should have 2 to 3 basic tests. That is, mainly we should have a serum creatinine level, we should have a blood urea nitrogen level, we should have a urinary spot sodium, and to look at and also look at the urine osmolarity to differentiate between a pre-renal acute kidney injury and an ATM. So, a patient with a pre-renal acute kidney injury will have very high urea levels. Urea levels in pre-renal acute kidney injury is very high. So, when we look at the blood urea nitrogen to the plasma creatinine ratio, it will be more than 20:1. For example, if somebody's creatinine is 1.5, whereas the urea is somewhere around 80 or 90, that means that the patient is having very high urea levels. That is more in favor of an acute kidney injury because of the pre-renal. And apart from that, you can have urinary sodium, which is very less, or patient is having high osmolarity of the urine. Fractional excretion of sodium is less than 1, which indicates that the patient has got pre-renal azotemia. So when you diagnose pre-renal azotemia, depend on your values of urea, fractional excretion of sodium, and the osmolarity. And these kind of patients respond to volume repletion by giving IV fluids and maintaining the good hydration. These patients would respond very well to the hydration. Whereas the patients with acute tubular necrosis or intrinsic AKI, the urea creatinine disproportionate is not elevated, fractional excretion of sodium is more than 2%, and urine osmolarity is less than 400. And here, the fluids will not improve. The repletion of the fluids will not have a much beneficial effect as compared to a pre-REM AKI. And apart from this, an intrinsic AKI patient will have a granular cast, cellular debris, or epithelial cast in the urine. That is how these are the basic tests to differentiate between a pre-renal acute kidney injury and an intrinsic acute kidney injury. The serum creatinine levels, blood urea nitrogen, and the urinary spot sodium is easily available in most of the laboratory. And once you advise the patients for these tests, you can easily differentiate. And when more urea and more ratio is high, you can give fluids to correct the azotemia. And then we'll move on to the next type of acute kidney injury, that is the post-renal acute kidney injury. The post-renal AKI, by the word itself says post-renal. That means there is a problem in the renal tubules, or it will be in the bladder, or it will be in the urinary outlet. So it can be both upper tract or the lower tract. Upper tract means from the renal pelvis, pelvic junction, ureters up to the bladder, and the lower tract is after the bladder, urethra, or the prostate. So this is how we classify acute kidney injury into the pre-renal, intrinsic renal, and the post-renal acute kidney injury. So what are the causes of upper tract obstruction? We all know that Many of the times the most common is the calculi, renal stones, which are causing this thing, or a patient with bleeding diathesis, or patient with diabetic presenting with papillary necrosis, malignancy, or it could be an excessive compression by any other malignancy or other vascular malformations. And causes of lower tract obstruction, especially is the ureteric stricture, renal calculi, bladder malformations, bladder cancer, or it could be a functional uh, functional obstruction of the bladder, that is the neurogenic bladder. So how do we assess the patient? We moved on to the assessment of AKI. AKI, you should always look at the patient. Okay. So when you have a patient with renal failure, you should always look at the patient history first. You should always take a focus history. Has the patient been having taking any medications in the past which can cause renal dysfunction? Has the patient recently been having any medical history, fever, low stools, or any other illness which has caused the renal failure? Or you should also thoroughly look into the patient clinical scenario. The patient has got any surgical marks, or the patient has got any fever, rashes, cardiovascular instability, any history of recent uh, procedures like IV contrast or CT contrast. These will help us to diagnose and treat the patients for acute kidney injury. Always look for a temporal link of exposure or risk factor for elevation in the creatinine or decrease in the urinary output. So, whenever you have a patient with renal failure, you should always assess the volume status of the patient. Volume status can be assessed by history and also the clinical examination. Whenever the patient has got a postural fall in the blood pressure, whether sitting blood pressure and we're looking at the standing blood pressure. Whenever there is a fall in the postural pressure, that means the patient is dehydrated. And also look at the intake output and also look into the signs of volume depletion, that is change in the skin turgor or sunken eyeballs or lethargic look are signs more of volume depletion. And further workup is very important. And for a nephrologist, a good urine routine evaluation is very much important. It is as good as getting a ECG for a cardiac patient. So urine routine microscopy tells us a lot and lot about this patient. So what you should look at the urine routine and microscopy, you look at the proteinuria, look at the osmolarity, look at any cast in the urine, look at the RBCs, WBCs in the urine, and this will help us to look into the etiology and workup of the renal failure. So this is what urinary sediment is very important, because if you have a patient with renal failure and on urine microscopy you see RBC cast that is more in favor of glomerulonephritis or vasculitis or thrombotic microangiopathy. WBC cast very commonly seen in interstitial nephritis, pyelonephritis, or in transplant graft rejection. And eosinophilia is very commonly seen in patients with allergic interstitial nephritis, atheroembolic disease. And many times even the urine evaluation shows many of the uric crystals in the urine, which helps us in diagnosis and management of these patients. So, patients with renal failure, never ever underestimate the importance of urine analysis. Get a very good urine routine analysis. Nowadays, it is very much freely available. Many of the dipsticks are available, which helps us in knowing what is urine analysis. And a very good microscopy examination is very important to look at the etiology and management of renal failure. And there was a study which showed which we looked into various markers of kidney damage in especially a surgical setting, that is mainly post CIBG setting. Here they found that the in a patient with post cardiac surgery, the renal failure setting was there, and they found that even though renal failure was already setting, the time taken for the serum creatinine to elevate was very longer. It did the serum creatinine, measured serum creatinine took a longer time to get elevated in a setting of an acute kidney injury in the post-operative setting. So this was the scenario which made us to think more and more about an early diagnosis of an acute renal failure, and that was the time where we thought beyond serum creatinine level. In our day-to-day practice, regularly we use very easily available and very cheap test, that is the serum creatinine level is available almost all centers. And but it has got some fallacies. Serum creatinine is not always elevated. It is not the first thing to get elevated in patients with acute kidney injury. So we need to know about other molecules or other molecules which get markers which are getting elevated in patients with acute kidney injury. So the most important other molecules are NGAL, that is neutrophil gelatinase associated lipocalcin, kidney injury molecule 1, cystatin C. These are the molecules which get elevated. These are the markers which are found in the blood even before the serum creatinine gets elevated. Here you can see that even before the serum creatinine is elevated in these patients of acute kidney injury, the NGAL is elevated little bit earlier. The kidney injury molecule 1 is elevated little bit earlier, and also the cystatin C is elevated earlier, saying that in patients with acute kidney injury, serum creatinine is not the best marker of acute kidney injury. So few words about cystatin C, and as I said, it is superior to serum creatinine as a surrogate marker of early and subtle changes of kidney function. It identifies the kidney injury, while serum creatinine levels normal in the early stage of kidney disease, and the elevation of the serum creatinine helps in detection of AKI 24 to 48 hours earlier than serum creatinine. Nowadays, some of the standard labs are doing cystatin C for your patients. And moving on to the complications, we all know that whenever the acute kidney injury is there, all the functions of the kidneys are affected, mainly the metabolic and the excretory function. The patient will have got fluid overload, hypovolemia, dyselectrolytemia, uremia, and this will have a lot of complications on the kidney, including cardiac failure, malnutrition, infections. So, few words on the treatment of AKI. Now we have seen a lot of reasons for AKI. What are the etiologies for AKI? Now, few words about the treatment of AKI. And in nephrology, there is a dictum where the ounce of prevention is worth a pound of cure. That means prevention is always better than cure. So, what are the things which help us to prevent AKI in our practice? Is always have optimization of the systemic and renal hydrodynamics through good volume resuscitation and judicious use of vasopressors, and try to minimize and eliminate the nephrotoxic drugs, especially the AC inhibitors, angiotensin receptor blockers, NSAIDs, and aminoglycosides in the patients with in the high risk patients with renal failure, and initiate dialysis and when well is indicated. And looking into the pre-renal AKI management, prevention and treatment of renal failure requires optimization of the renal perfusion, and severe blood loss should be treated with packet cells. And the guideline says, the KDIGO guideline says, the crystalloids are always better than the colloids. The crystalloids are very much important in improving the renal perfusion. Wherever colloids may be chosen in some patients to avoid excessive fluid administration, which requires large volume resuscitation and in these patients, and crystalloids are always better than the colloids. Vasopressors always try to maintain the blood pressure. There is no specific drug which is better than the other. Generally, whether it is adrenaline, noradrenaline, dopamine, try to manage the BP of this patient and keep a mean arterial pressure of more than or equal to 70. And there is no use of low-use dopamine in prevention and treatment of renal failure. Any of the drugs which increases blood pressures are more important, and KDIGO recommends not using low-dose dopamine to prevent or treat acute kidney injury. And a few words about cirrhosis and hepatorenal syndrome. Today's hepatorenal syndrome is because of the abnormal function of the liver, which leads to renal dysfunction. Here, the good outcome nowadays we have seen with good use of albumin, terlipressin, octreotide, and midodrine, which improves the vascular perfusion of the kidneys. And a few words about cardiorenal syndrome. The cardiorenal syndrome means renal dysfunction secondary to a cardiac dysfunction. It could be an acute or chronic or causing renal dysfunction. Here, the main aim of the situation is to improve the cardiac function by use of inotropic drugs, afterload or preloading agents, mechanical aids such as intra-aortic balloon pump in critical care settings. Moving on to the intrinsic artery kidney injury and the use of diuretics. And it was found that they have little amount of renoprotective effect by potentially lessening the ischemic injury. And a patient with renal failure doesn't mean that all of these patients will require diuretic. Sometimes it can be harmful by worsening the established acute kidney injury. And KDIGO guidelines recommend not using diuretics to prevent AKI. Okay, so don't use diuretics to treat AKI. However, Classics or diuretics are to be given only for the management of fluid overload, hyperkalemia, or hypercalcemia. So if your patient has AKI has got fluid overload, then only use Lasix. If the patient is volume depleted, don't try to use Lasix or diuretics. Rhabdomyolysis is because of the intrinsic renal kidney injury because of the endogenous toxins. Here you should have aggressive volume replacement. Alkalize the fluid is beneficial, and dialysis in the optimal setting is having good outcome. And a few words about glomerulonephritis or vasculitis. This is a very specific and very pertinent issue in patients with renal failure, where the diagnosis of glomerulonephritis or vasculitis basically is done following a renal biopsy. So, renal biopsy is done for diagnosis of glomerulonephritis or vasculitis in most of the settings, and these patients they require specific type of therapy that is mainly immunosuppressive drugs. It could be steroids, it could be tacrolimus, mycophenolate, or if there are pre-existing antibodies which are to be removed with plasmapheresis. And this kind of acute kidney injury setting requires a renal biopsy to know what exactly has happened to the kidney. And once you get a renal biopsy, then only you treat this kind of glomerulonephritis or vasculitis. Few words about aminoglycoside-induced AKI. Patients with a clinical setting of probably getting a renal failure, try to avoid using aminoglycosides. If at all you use aminoglycosides, use as a single drug. Don't give a single dose. Don't give multiple doses or twice a day or something like that. Give once a day aminoglycosides to get a maximum benefit and minimize the side effects of this drug. And post-renal AKI, and this has got a very good outcome because you know that there is obstruction in the kidney urinary bladder, the genitourinary tract, and the post-renal AKI they do very well after surgical correction or prompt bypassing of the obstruction. And however, we should know very well that a post-renal AKI, they have a lot of diuresis. Once the obstruction is relieved, the patient may go into a dehydration or dyselectrolytemia. And patients with post-renal AKI, that you have like, for example, you have a bilateral renal calculi, you put a renal kidney stent, post-operatively you can have a lot of urine. So dyselectrolytemia has to be managed very well in these kind of patients by looking into the electrolytes and also the hydration status. And most importantly, when do you need dialysis in patients with acute kidney injury? The mnemonic what we have is the AEIOU, that is prevention of uncontrolled acidosis, prevention of uh, treatment of uncontrolled acidosis, treatment of uncontrolled hyperkalemia, and volume overload or uremia. These are the important indications for dialysis. Apart from this, we do dialysis for even drug intoxications like lithium, methylene glycol, and others. So what are the modes of dialysis which we have? Which we have the regular dialysis, which we do for maintenance dialysis, that is called as the intermittent hemodialysis. Or in patients who are critically ill or hemodynamically unstable, we can do what is known as continuous renal replacement therapy or a slower form of dialysis that is called as a SLED. So all the hemodialysis is not only done to treat renal failure, we can even use the dialysis setup to treat many of the drug overdose or poisoning. This is carbamazepine, ethylene glycol, lithium, methanol, methotrexate, salicylate, theophylline, and valproic acid. Here, what happens is in hemoperfusion, we use the hemodialysis machine, but the blood runs directly through a charcoal filter or a sorbent-containing filter. Here we can see that the hemodialysis setup is there, but instead of the blood passing through this dialysis filter, we are passing the blood through these cartridges, which are basically a charcoal filter or a sorbent-containing filter, which helps in removing the drugs or toxins from the body. The looking at the prognosis of pre-renal and post-renal acute kidney injury is always good, and most of these have very good prognosis. And there are many incidences where the patient and kidney has recovered even after having a few sessions of dialysis. However, there are few cases of acute kidney injury which may eventually progress to chronic kidney disease. This happens in less than 10% of the cases which are dialysis dependent. So to end to end my talk, I want to say all of you that diagnose acute kidney injury very early, and serum creatinine is not always elevated in early stages of kidney disease. Biomarkers can have a great potential. And when looking at the diagnosis and management of kidney disease, try to look at the etiology of the renal failure. And as I said, prevention is better than cure. But not only that, prevention is the cure, is what I always believe. And there is no role of low dose dopamine diuretics in prevention and treatment of acute kidney injury. And don't hesitate to refer and, and send these patients to higher center when you feel that the patient is not improving adequately. And initiation of dialysis, that is renal replacement therapy, is indicated whenever is clinically indicated, and prognosis is always determined by the etiology. The, thank you all for a patient hearing. Any questions, I'll be happy to answer and share my thoughts. Thank you, one and all. Hello. Hello. Yes, sir. Any questions? I'll be happy to take the questions.
Hello,
Hello.
John. Yeah. Thank you, sir.
Yeah,
Thank you,
you
Dr.
can
Ravi,
ask
sir,
questions.
for excellent talk with the clinical scenario of acute and chronic renal diseases. Yeah, if any member want to have clarify questions,
I
can
think
ask.
Dr. Pradeep Dongre want to ask question. He can now. You can unmute and you can ask.
At the outset, I really thank Dr. Ravi for giving such a exhaustive talk on acute kidney injury, especially on acute kidney injury. And there are some situations where I found it very difficult in the intensive care unit to treat, especially we had a recent incident where we just couldn't make out whether it was a pre-renal AKI or an AKI due to an amniotic fluid embolism. We had a very severe metabolic acidosis, in fact, and in fact, we did do a scan. The IVC was collapsible, but the metabolic acidosis was not, correctable with SLED also, and we just lost the patient. Bleeding was not much, but there was no a thready pulse, immediately after delivery, and we never recovered. So, is there anything other thing that we could probably do, or do we start dialysis early, even with the first onset of, metabolic acidosis or something like that? We can do.
Yes, yes. Thank you, Pradeep, for the comment. And as rightly you said, the clinical setting which you were discussing, that was a case of possibly amniotic fluid embolism with patient in shock. And theoretically, we can have so many things in our this thing. It could be pre-renal, intrinsic renal. But when we do clinical practice, there is nothing which is coming as a single entity. It can be a combination of pre-renal or an intrinsic renal. Or many a times when the patient is having sepsis, there could be some amount of post-renal also. And that is one thing. Not patient presentation is not always a single entity. It could be a combination of both intrinsic renal and also pre-renal. Like in this patient, we have hypotension, and also there is probably some amount of sepsis and shock which cause more of intrinsic. So there is both the thing in your patient. And coming to the management, and as you said rightly, the hydration part is very important because the patient is having so much feeble pulse. The IVC was collapsible. So hydration was very important in this patient. And the third point, which you said that you had given a very good dialysis for this patient. And there is one thing which there is a point of no return. Not generally, I say, where you say you want to start dialysis to correct acidosis, and these patients will be having very bad acidosis. And acidosis, the thing acidosis which get corrected with dialysis modalities, that is continuous renal replacement therapy or SLED, is more of metabolic acidosis. And but if the patient has got an additional lactic acidosis, which is very difficult to get corrected with a good hemodialysis, because lactic acidosis is more telling that the patient is having a hypoperfusion, the cellular hypoperfusion is there, and these kind of patients require more of hydration in the patients, and in coverage of good antibiotics, which helps to improve the tissue perfusion. So if we have both metabolic acidosis and additional of lactic acidosis, these patients are very difficult to treat. They don't generally improve very fast until unless we have a correctable cause. So that is what I want to say here.
Thank you, sir. Any other questions? We have to close before 1 hour. I think 1 hour
Good evening,
sitting
sir.
is there.
Sir, yes, sir. I have a question, sir.
Yeah, please.
Good evening, sir. My name is Dr. Tanmay Dhawan. I'm from Lucknow. So your lecture has the Pan-India presence today. I just wanted to ask you a few questions, like regarding infections which lead to AKI. Especially, we are coming into a season. I'm from Lucknow, so we are coming into a season of dengue and malaria. So when the patient enters the critical phase in dengue and there is volume overload, and patients usually develop AKI. If we can have a session on that in the future, like it will be very beneficial for us. How to manage the AKI in infections, especially dengue, because when patient enters the critical phase, there is volume overload as well as the patient is developing AKI, and there have been off paper indications for albumin as well in those cases. So, what are your like? Can you guide us through that a little bit?
Yes, sure. Thank you very much for attending this seminar today. And these two kind of scenario where you mentioned dengue hemorrhagic shock and the malaria associated renal failure, and dengue hemorrhagic fever, as the name indicates, says that more of hemorrhagic, where there is lot of capillary leak, and the patient will most of the times will be in shock and with lot of bleeding diathesis, and patient with multi-organ dysfunction. And definitely, this is a challenging case for dialyzing, taking these patients on dialysis. Okay? And there is always a discussion about when to start. Either the early stage of dialysis is good or late initiation is good. Some people do it aggressively, and some people want to wait time for initiation of dialysis. But either way, the outcome depends on how well the patient is responding to your hydration or resuscitative measures, and that is more important. And dialysis is very helpful in resuscitating these patients. Once the hydration and other colloids are all very much crystalloids are easily given to these patients. Like supportive care is more important than an early start of dialysis. That is what I believe. And definitely in future discussions in this podium, we can have more and more such discussions about sepsis related acute kidney injury and more and about those things. And there are few studies which have used cytotoxic absorbing dialysate filters, and each filter costs around 80,000 to 1 lakh. When the same kind of dialysis is done and the blood is passed through these cytoabsorptive filters, they have found some good outcome. But these kind of treatment are very expensive. The filter itself costs about 80,000 to 1 lakh, and there are few studies which says that they have done these kind of dialysis mainly to decrease the cytokines in these patients. And definitely you can try in your patients also.
Sir, does statin C helps us if we do it in the early phase of the dengue to predict the creatinine levels,
Yes.
whether the patient will go into critical phase or not. Does these works in infections as well?
Yes, definitely. So acute kidney injury, cystatin C is very much helpful in early diagnosis and treatment. And apart from this, you should always look at the urinary output also. And both the things combined will give us a better understanding about this patient and also the treatment options. Combine both cystatin, creatinine, and also the urinary output protein.
Thank you, sir.
Thank you. Thank you, sir. Dr. Manjunath, if there are no questions, please propose the vote of.
Hello. Thank you, Dr. Ravitya, for the wonderful and informative session. Thank you very much. And also, I thank our IME case President, Dr. Srinivas sir, and our IME case Secretary, Dr. Srinivas Suri Raju sir, for joining and blessing the application. And I thank our IME AMS Chairman, Dr. S. Y. Murthy Patel, and all other participants for joining this informative session. Thank you, everyone.
Thank you, everyone.
Thanks to our secretary also. Thank you, sir. Ravi sir. It was a really nice talk.
Thank you, sir. Thank you, everyone. Thank
Yes,
you for
yes.
encouraging.
Right. Thank you so much for all. Good night.
Good night.
Good night. Good night.
Good night.